This 3D rendering displays the maternal-fetal vascular interface. Throughout late-stage pregnancy, a strict physical boundary isolates the amniotic fluid from the maternal circulation. If a microscopic tear compromises that boundary, fetal fluid crosses the barrier, triggering a rapid and devastating systemic alert across the surrounding blood vessels. This event is known as an amniotic fluid embolism, or AFE. It is an exceedingly rare but highly lethal obstetric emergency. The condition typically strikes during late pregnancy. However, the exact same reaction can occur earlier, specifically when an abortion is performed during the first or second trimester. Despite its rarity, the mortality rate is so severe that among women who die suddenly during labor, an amniotic fluid embolism is one of the most likely underlying causes. The term embolism usually implies a physical blockage, like a blood clot. In AFE, fetal materials instead trigger a massive systemic reaction throughout the maternal bloodstream. This initial reaction triggers a secondary, paradoxical complication, disseminated intravascular coagulation, or DIC. This is a state of massive coagulopathy that severely limits the patient's chance of survival. Surviving an AFE requires an immediate, aggressive, and highly coordinated response from a multidisciplinary emergency care team executing simultaneous resuscitation protocols. Because AFE causes both cardiopulmonary collapse and total hematologic failure at the same time, anticipating and reversing the crisis requires critical care teams to intimately understand the underlying pathophysiology of the cascade. The mechanical prerequisite for an AFE is straightforward. There must be a physical breach in the vascular barrier separating the amniotic sac and the maternal circulation. This systemic diagram of the uterus maps the specific risk factors that make a physical breach more likely. The first category involves anatomical issues that physically compromise the vascular barrier. Key anatomical vulnerabilities stem from placental abnormalities. The risk increases if the placenta is in the wrong position, placenta previa, if it has an abnormally firm attachment to the uterus, placenta accreta, or if it detaches prematurely, placental abruption. Physical trauma directly compromises the barrier as well. A severe abdominal injury, a uterine rupture, or a tear in the cervix all create direct pathways for fluid exchange. Routine and emergency delivery interventions also introduce physical trauma risks. The structural manipulation required when using forceps or the surgical incisions of a cesarean delivery inherently compromise the tissue barrier. A compromised barrier alone is not always enough to force fluid into the bloodstream. A second category of risk factors provides the necessary mechanical force, conditions that increase intrauterine pressure or volume. Excessive volume acts as a pressurized wedge against the uterine walls. This occurs in cases of polyhydramnios, where there is simply too much fluid around the baby, or when a mother is carrying multiple fetuses, such as twins or triplets. Medically induced labor also amplifies this mechanical risk, as the administered medications force intense, artificially generated pressure contractions. These combined physical and pressure-based risks are further compounded by underlying systemic variables, specifically older maternal age and conditions like eclampsia. When anatomical vulnerability meets elevated intrauterine pressure, the mechanics align to force amniotic fluids straight through the compromised barrier into the maternal bloodstream. In this video simulation, we see the exact moment amniotic fluid particulate enters the venous return. It mixes aggressively with the blood, traveling quickly upward until it directly hits the maternal heart and lungs. This infiltration dictates the strict clinical timeline of the event. The intense physiological reaction typically manifests precisely during or in the very short window immediately following labor and delivery. This simulated clinical dashboard illustrates the immediate effect of the fluid on the patient. The reaction instantly and violently destabilizes the cardiovascular system. The first measurable clinical signs reflect cardiac distress. The heart rate rapidly accelerates into tachycardia, and the rhythm becomes highly erratic and irregular. In tandem with the heart's erratic behavior, the vascular system collapses, resulting in profound, dangerously low blood pressure. The lungs follow immediately. The patient falls into rapid respiratory failure, struggling with sudden, severe difficulty breathing or stopping breathing entirely. Without immediate intervention, this progression ends in sudden cardiac arrest. The risk of maternal death at this stage is exceptionally high. This presentation represents a simultaneous cardiopulmonary collapse, requiring doctors to recognize the tetrad of symptoms instantly. While the cardiopulmonary collapse is occurring, the body initiates a secondary reaction that actively sabotages the resuscitation effort: disseminated intravascular coagulation. This cross-section of a maternal blood vessel shows how a healthy system operates. Proteins called clotting factors circulate freely within the blood plasma, waiting to repair isolated injuries. The presence of amniotic fluid triggers a paradoxical reaction. Instead of targeting a specific injury, the system short-circuits. Thousands of small blood clots suddenly develop and lodge throughout the entire maternal bloodstream. By forming so many microclots at once, this widespread reaction rapidly consumes and completely exhausts the body's entire reserve of available clotting proteins. This systemic depletion has disastrous consequences at the delivery site, where the uterine tissues have just been structurally compromised by childbirth. Because the body has no clotting factors left in reserve, the result is massive, widespread, and entirely uncontrolled bleeding. Recognizing this invisible internal depletion is a diagnostic imperative. Doctors must urgently perform blood tests to check the function and availability of these clotting proteins. DIC effectively weaponizes the body's own defense mechanisms. It turns a severe cardiopulmonary arrest into a dual system failure, forcing the patient to bleed out massively at the precise moment her heart stops beating. The response to this crisis is triggered by recognizing a strict tetrad of symptoms: the sudden stopping of the heart, sudden difficulty breathing, plummeting blood pressure, and widespread uncontrolled bleeding. This split-screen clinical schematic outlines the necessary response. Survival requires a team of specialists executing a dual-track resuscitation, utilizing advanced intensive care equipment. Track 1 is cardiopulmonary. The team must immediately begin CPR and aggressively assist the patient's breathing to maintain oxygenation. Pharmacological support is deployed on this track, specifically administering medications designed to force the failing heart muscle to contract. If CPR does not immediately resolve the cardiac arrest, the protocol dictates emergent action. The baby must be delivered instantly using forceps, a vacuum device, or a rapid cesarean delivery. Emptying the uterus serves a critical dual benefit. It removes physical pressure on the major maternal blood vessels, improving the mother's chance of survival, and it is a life-saving intervention for the fetus, provided the fetus is old enough to survive outside the womb. While CPR and delivery are underway, Track 2 addresses the hematologic failure. To counteract the DIC, the team initiates massive transfusions of whole blood and blood components, alongside life-saving injections of concentrated blood clotting factors. To physically stop the massive blood loss at the delivery site, doctors administer specific uterotonic medications. These induce strong uterine contractions, forcing the tissue to clamp down and mechanically restrict further bleeding. Successful resuscitation in AFE requires fighting the cardiac and hematologic failures at the exact same time, as sequential treatment is ineffective. The entire crisis originates from a distinct mechanical failure, a physical breach at the maternal-fetal interface, driven by anatomical vulnerabilities and elevated uterine pressure. This breach initiates the primary physiological reaction, a catastrophic and immediate cardiopulmonary arrest. Simultaneously, the fluid triggers the secondary reaction, disseminated intravascular coagulation, which rapidly depletes the body's clotting factors and causes massive hemorrhage. This timeline charts the path to stabilization. Clinical interventions directly counteract both physiological failures in parallel. The survival window is exceptionally narrow, relying entirely on the team's ability to promptly diagnose the tetrad. Once diagnosed, stabilization requires intense CPR, emergent delivery, and massive blood replacement. Amniotic fluid embolism remains one of the most severe emergencies in medicine. But by understanding the pathophysiology of the lethal cascade and the coagulation paradox, medical teams can execute anticipatory, life-saving action precisely when seconds matter most.